Welcome to my newborn assessment video. Today I will be performing a newborn assessment, as you might have guessed. My name is Noelle Ross and I will be the nurse for the video. So just a couple of things I would do before entering the patient's room. I would check the provider's previous orders to see if there's anything I need to follow up on while I perform my assessment, as well as the client's care plan. And then I would also gather any supplies or equipment that I would need to complete the assessment, which just today's video I'll just be using a stethoscope. So once I enter the patient's room, I would introduce myself as the nurse for the day and that I would be performing a newborn assessment. And then I would ask the patient to identify themselves as well as identify the child. I would check the client's answers against the medical charts as well as if they're wearing any hospital bracelets. I would provide privacy by closing either a curtain or closing the door to the room, and then I would perform hand hygiene before doing anything. Some things I want to keep in mind while I'm performing my assessment is the alertness of the infant as well as its behavior. Is it sleeping? Is it awake? Is it content? Is it upset? And then I would be looking for any signs of pain from the newborn, which can be displayed through facial grimacing, inconsolable crying or irritability, and then any grunting noises or breath holding would also be important to take note of, as that could be a sign of respiratory distress. I would also want to kind of gauge how the mother perceives the infant and assess the level of maternal newborn bonding, and note if the mother has family support with her or if she's alone or not. So before I disturb the newborn, I would want to try and assess the nutritional status. By doing that, I would either look back in the chart to see when the last time the baby was fed, or I would ask the mother if it wasn't documented. And then I would ask what form she's doing, if she's either breastfeeding or if she's doing a formula feed. If she's breastfeeding, I would ask how frequent the feedings are, which they typically should be every 3 to 4 hours. If she's formula feeding, I would ask about the average of ounces the baby will take, and then also ensure that the feeding should be every 3 to 4 hours. Another thing I would ask the mother is if the child has any difficulty feeding or if she seems uninterested, then that's something we would need to look further into because there could be something more going on. I would also assess the hydration status of the child, and I could do that by assessing her skin turgor or the palpation of the fontanelle, the anterior fontanelle of the skull, which would be right up here. It should be flat and even with the rest of the skull. However, if the child is dehydrated, then the fontanelle will be sunken in, and if the child has too much fluid, then it would be bulging. Both of which are not good and would need further interventions. So beginning the assessment, I would perform hand hygiene, wash my hands, hand sanitizer, and then put on gloves. I would transfer the baby to a warming table to maintain the baby's temperature throughout the assessment. For the purpose of this video, I have a warming pillowcase. And then I would remove the child's clothing so I can do a good assessment of her skin. Okay. And then next I would listen to the heart sounds, but I want to remember to warm the stethoscope with my hands, just like that, before I place it on the child's skin, to prevent any heat loss via conduction. When I listen to the heart sounds, I will be listening where each valve is located, and I will be listening for clear S1 and S2 sounds, and I should be able to hear strong regular beats with no murmurs present. I will verbalize for you where each of the valves can be heard. So this is the aortic valve, the second intercostal space, right sternal border. Clear S1 and S2 sounds, strong regular beat. The pulmonic valve, the second intercostal space, left sternal border. Again, clear S1 and S2 sounds, strong regular beat, no murmurs present. I would go down to Erb's point, which is the third intercostal space, left sternal border. And then I would move down to the tricuspid valve, the fourth intercostal space, left sternal border. And then the mitral valve, the fifth intercostal space, left midclavicular line. And after it's determined that all the valves are strong and have regular beats with no murmurs, I would obtain an apical heart rate, which should be between 110 beats per minute and 160 beats per minute. I can do this by listening for 30 seconds and multiplying by 2, or listen for a full 60 seconds. So after it was determined that the heartbeat was within normal limits, I would then go on to observing respirations. I would first want to assess the respiratory effort and make sure there's no intercostal retractions, no nasal flaring, as well as no grunting, as those are all signs of respiratory distress. I would then also look at chest expansion, as it should be symmetrical. And then I would also count how many breaths per minute the child has. The typical range is between 30 and 60. Again, I can account for 1 minute, or I can count for 30 seconds and multiply it by 2. Auscultating the respirations, I would first check for clear air entry and noting any signs of stridor. No signs of stridor are present. I would then listen to each lobe of the lungs, looking for clear breaths and no congestion. So no congestion or crackles is present, and the respirations are within normal limits, between 30 and 60 breaths per minute. Moving on to a skin assessment, I would want to just look at the overall skin tone of the child, and it should be an even tone throughout the whole body. The child may present with signs of acrocyanosis, which is a normal finding after birth, and that just means that the hands and feet may have a bluish purplish tint to them as circulation is trying to get there. It's a normal finding again, and it should typically goes away 24 to 48 hours after birth, so it's nothing for the mother to be concerned about. While I'm looking at the skin, I want to make note of any signs of Mongolian spots or any birthmarks that the child may have. So while I'm doing my skin assessment, I also want to make note of any signs of yellowing of the skin, which is a sign of jaundice. By doing that, I can just lightly press on the child's forehead or the tip of the nose, and if it appears yellow after I remove my finger, then that typically means the child has jaundice. Another way to tell is by looking at the sclera of the eyes. If the white sclera appears to be yellow, that is also a sign of high bilirubin levels. So the bilirubin level will typically be checked before discharge, as well as 3 to 5 days after birth, when the levels are the highest. Phototherapy is a suggestion for treatment if the bilirubin levels are extremely high. After performing the skin assessment, I would go on to the head assessment, and I would want to note the size, the shape, and the symmetry of the head. Also want to note any signs of the caput, which is the crown of the head, typically disappears within a few days after birth. I would also note any signs of a cephalohematoma, just damaged blood vessels after a difficult delivery, and that's usually just blood pooling under the skin, and we would typically just leave the area to heal itself, and then the body would reabsorb the collected fluid. I would also want to palpate the anterior fontanelle. Again, it should be soft and flat and even contour with the rest of the skull. If it's sunken, that means the baby is dehydrated, and if it's bulging, that means there's too much fluid. Continuing with the head assessment, I would also want to turn to the facial features, as they should also be symmetrical. I want to look at the placement of the ear. The top of the ear should be in line with the outer canthus of the eye. I would also want to note the presence of the ear canals and ensure that they're both there. I would also be looking for any signs of a cleft lip or cleft palate. Both the hard and the soft palate should be visible and intact. Looking at the eyes, I would want to note the color of the sclera. They should be white, however, if they're a yellowish color, that could indicate jaundice. Also, I want to note the pupil size, the shape, the position of the pupil, as well as the reactivity. And then also taking note of any abnormal gazing that the child may do. Moving on to the nose should be symmetrical in shape and both nares are present. And there should be no signs of nasal flaring or grunting, as again that could indicate respiratory distress. So moving right on down to the neck, I would want to note any visible signs of webbing of the neck, as this could be a sign of a congenital anomaly and would need further testing. I would also want to check and palpate for any signs of massing or signs of nuchal cord thickening, which nuchal cord thickening is an increased thickness of the skin at the base of the neck. I would also want to assess the clavicles and make sure that they are intact bilaterally. They could have become broken, especially if the child had shoulder dystocia during birth. I would also assess for the presence of stork bites, which are patches of redness, usually just above the hairline here at the back of the neck. And that just means there's patches of capillaries that grow close to the skin, and they will fade as the child grows. There's typically no treatment for them. So stork bites could also be seen on the child's face, either on the eyelids or between the eyes. So next thing I would do is a chest assessment. I would assess for the evident xiphoid process, as it should be midline on the child. I would also look for bilateral synchronous chest movements for breathing. And I would want to make sure that the nipples are present and symmetrical. After the chest assessment, I would want to assess the abdomen. And by doing that, I want to auscultate for bowel sounds. They typically should be present within 2 hours after birth, and I will listen in all 4 quadrants. So the bowel sounds were present. I would also want to note the shape of the abdomen. It should be dome-shaped and soft to palpation with no intercostal retractions while breathing. And I would also want to note if any masses or hernias are felt. Still in the abdominal region, I would want to assess the umbilical cord stump. Just looking for any signs of bleeding, oozing, or signs and symptoms of an infection, which those would be redness, swelling, warmth at the umbilical site. If the umbilical cord should be clamped, and it should be drying with no herniations at the base. The diaper should be pulled away from the umbilical stump to reduce any irritation. And I would also want to look at the umbilical stump for the arteries as well as veins. There should be 2 arteries and 1 vein present. Moving on to assessing the extremities, I would want to make sure that there is movement and muscle tone in all 4 extremities. In the arms and hands, I'm checking for symmetry in the size and shape, the appropriate number of digits as well, and no signs of webbing. In the legs and feet, again, I'm checking for symmetrical size and shape, as well as the appropriate number of digits on the toes and no signs of webbing. I would also want to check for the femoral pulse. Bilaterally, it should be present, and it's just in the crease of the hip. So I would palpate both sides is present. Then I would do a spinal assessment, and I would inspect and palpate the alignment of the spine, as it should be midline and intact. Also at this time, I would note any Mongolian spots on the back or the bottom. If there's any skin disruptions, sacral dimples, or tufts of long hair along the spinal column, it could indicate underlying conditions, pretty serious ones as well, such as spina bifida or tethered cord syndrome, which they would need further interventions. So next, I would assess the child's reflexes. They should all be intact and present. The first one I would look for is the rooting reflex, which is just stroking the child's cheek, which prompts the head turn in the direction that I stroked. I would also check for the sucking reflex by inserting a pinky upside down into the child's mouth, just the tip of it. That would elicit the child's sucking reflex. To assess the Moro reflex, I would elicit a startle to the child, either by making a loud noise or a sudden movement. The arms and legs should suddenly extend and then contract back into the trunk. I would hold the child somewhat off the table, maybe the legs still on the table, and then I would quickly move the child down, almost in a falling motion, but not letting go of the child, and that would elicit the Moro reflex response. Next, I would check for the palmar and plantar grasp. I would give my finger to the baby. This would be the palmar grasp if she curls her fingers around mine. The plantar grasp would be also putting my finger under the child's toes, and the child's toes would curl around my finger. To check for the Babinski reflex, I would stroke the sole of the child's foot, going in an upward motion around the toes. That would elicit the toes to fan out, which is a normal finding in children for up to 2 years old. So for a gastrointestinal or a genitourinary assessment, I would know that the baby should void within 24 hours of birth, and the meconium should be passed within 24 to 48 hours of birth. If they have already been passed, I would note the time that it passed, the date, the color, the amount, as well as the odor. If I had a male newborn with me, I would do a genital assessment looking for normal genitalia. I would palpate for the presence of testes in the scrotum or the inguinal canal, as well as checking for the presence and placement of the urethral opening. I would also want to check for any hydrocele, which is inflammation in the scrotum that occurs when fluid collects surrounding the testicle. If the newborn was a female, I would also be looking for normal genitalia. I would assess for the presence of the labia minora, the labia majora, as well as the clitoris. And I would also note the presence and placement of the vaginal opening and noting any vaginal discharge. At this time, I would also want to do a rectal assessment, checking for the patency of the rectum. I want to elicit an anal wink, which is stroking the perineal skin with a pin or a probe, and the anal sphincter should contract visibly and pucker at the anal margin. Failure to elicit this reflex could indicate peripheral or sensory motor nerve damage. If the child was born via a cesarean birth, I would want to observe for any injuries that could have occurred during the procedure. That could be any lacerations that the child may have. I would also want to note any signs of congestion, as that is more prevalent with cesarean births. After my assessment is finished, I would replace the clothes on the child, return the child to the mother, take off my gloves, perform hand hygiene, and then document all my findings as appropriate.